chose this case actually as one of my most difficult FM pop cases, but after seeing the procedure this morning, the last one of the morning session, the live case, I think this is actually an easy one. It's a 69-year-old female with bilateral claudication, Rutherford class 3, with on duplex a bilateral occlusion of the SFA, and an MR angiography that was performed elsewhere showed patency of the aortic and iliac axis with a bilateral occlusion of the SFA and probably no stump. The image quality was not very good, as you can see from this image. So what we planned to do was an endovascular treatment of both sides, left side first because the complaints were worse at that side. I typically use a antegrade puncture of the left common femoral artery, 4 French introducer to start with, diagnostic angiogram, recanalization, PTA and stent. And this is the image, the first image of the diagnostic angiogram. You can see a flush occlusion of the SFA, common femoral and the profunda are widely patent, and here you can see the distal outflow. There's a large branch of the profunda with several collaterals going into the distal SFA where there's a good pickup, and then this is the distal outflow. It's very slow, and you can see that there is a 3-vessel runoff. So here you can see the 3-vessel runoff, and this is actually the summary. Flush occlusion of the SFA, no proximal stump, pick up distal SFA through large collaterals. Treatment options obviously can be done very easily by converting to bypass, but that's not the case. Antegrade crossing might be difficult because there is no stump. We can perform a distal puncture, as was explained this morning by Diagnostic, with a distal SFA or popliteal artery puncture, or a P2 puncture in the prone position, or a recanalization through collaterals. This is an attempt to recanalize antegrade. We couldn't get in at no point here anymore. You can see this branch, which is the branch that becomes very important later on in the presentation, so keep that one in mind. I decided not to puncture distally. Patient was not really informed for that and not prepped for that. What you can do is an antegrade and retrograde wire and balloon passage, or an antegrade retrograde wire passage and then perform a balloon passage antegrade. So here is the first roadmap. You can see a diagnostic catheter 4 French multi-purpose into the large branch of the profunda, and here you can see the distal runoff, and the idea was to get through these collaterals into the distal SFA back again. This is a coaxial system with a 4 French multi-purpose catheter and a 2.7 French microcatheter inside and an 018 guide wire. But it was not possible to get beyond the point that you see here with the microcatheter, so this path was abandoned. Then I tried another collateral. There are many of them, and here you can see the projected pathway that the microcatheter had to take, but also that one appeared too difficult, as you can see here, from for a passage. So again, moving on with the second attempt, it was a second failure, and then there was another collateral. And although this route seemed very difficult and much more tortuous as compared to the other two that I just showed you, it was relatively easy to cross with the microcatheter and its guide wire. Here you can see the movie. Here we have the support catheter 4 French with an 038 lumen. That's important to get the 2.7 French through, and then you can advance your guide wire and catheter. Here you can see the tip of the catheter moving upwards, and then the next video shows you the re-entry into the SFA all the way up with now the guide wire looped. Then it's relatively easy to get a retrograde passage with the 4 French catheter now exchanged for a CXI and 018 long advantage guide wire, it was possible to move the CXI in a retrograde fashion into the distal SFA and then looping the guide wire up until the groin, where re-entry was very easy. In most cases, it's then very easy to come with a second guide wire next to the 018 guide wire in an antegrade fashion after pulling back the 4 French catheter, but in this case it was not possible to align the 2 guide wires. So we removed the coaxial catheter system, an 035 and an 018 will fit into a 4 French sheath, and here you can see that it was not possible to connect the 2 pathways. Then a cart was performed using the 018 guide wire with a low profile balloon, pre-dilatation, and then afterwards it was possible to connect the 2 channels with a rendezvous procedure, and then antegrade passage of the initial guide wire, the proximal guide wire was possible. Here we can see the confirmation of the intraluminal position of the 4 French diagnostic catheter. This is then a control angiography prior to balloon angioplasty. And you can see that all the collaterals are still present here, so no harm was done by using this collateral pathway. Balloon angioplasty was performed. Here you can see the result of balloon angioplasty, and then a 4 French compatible stent system was placed. That's the reason why I stuck to the 4 French. This is something that is available in Europe. Here you can see the pre-stent, post and stent placement, and this is the post-stent control angiogram. Good outflow, direct flow to the 3 vessels with no signs of distal embolization. So why use the collaterals just to make your life more difficult? Actually, you can just puncture relatively easy and do the same procedure with a bilateral or bifocal approach. But I think the antegrade approach is more versatile, and you have most of the time that already available. There are some practical reasons, the logistics. You might not have ultrasound to perform distal puncture. You don't need any additional prepping of the patient. You don't need any distal hemostasis. And of course, if you don't have experience with the distal punctures, this might be also a solution. What I think is also very important is that when performing a procedure like this, you have less risk of radiation exposure to your hands. Oftentimes, especially when you use a fluoroscopy-guided puncture of the distal SFA or pedo axis, most of the time you're very close with your hands to the X-ray beam, and that is something that I like to avoid. So I think, to conclude, the use of collaterals in the SFA recanalization may not be your first choice, but I think you should think about it before abandoning a procedure.